وأنت أرحم الراحمين فاستجبنا له فكشفنا ما به من ضر وآتيناه أهله ومثلهم معهم رحمة من عندنا وذكر للعابدين وإسماعيل وإدريس وذا الكفل كل من الصابرين وأدخلناهم في رحمتنا إنهم من الصالحين وذا النون إذ ذهب مغاضبا فظن أن لن نقدر عليه فنادي في الظلمات أن لا إله إلا أنت سبحانك إني كنت من الظالمين فاستجبنا له ونجيناه من الغم وكذلك ننجي المؤمنين وزكريا إذ نادي ربه رب لا تذرني فردا وأنت خير الوارثين فاستجبنا له ووهبنا له يحيى وأصلحنا له زوجه إنهم كانوا يسارعون في الخيرات ويدعوننا رغبا ورهبا وكانوا لنا خاشعين.
Sadaqallahu al-Azim. Over to you, Dr. Masood Umar.
Jazakallah. Thank you. Bismillahir Rahmanir Rahim. Allahumma salli ala Sayyidina Maulana Muhammad wa alihi barik sallim alayhi. I welcome all the participants today in the 31st webinar of Pak OrthoCon. It will be now Pak OrthoCon 2021. Today we have selected a difficult and challenging topic for those who are interested to learn more about bone defects, especially on the acetabular side and how to manage them. We have with us very enlightened faculty with Professor David Maria Donati, who is also my mentor and was my professor during my fellowship in Italy in orthopedic oncology. And we have since maintained a very good relation with Professor Donati, and he has been kind enough to visit Pakistan twice in previous orthocons, and has been very helpful in my personal academic and professional build-up. And secondly, we have Mr. Martin. He's a design engineer with Link, and he would take us through his experience of developing these implants and the concept behind using mega prosthesis on the acetabular side, concept behind 3D reconstruction of such implants. Lastly, we will have Dr. Nasir Ahmed, who is a consultant at Liaquat National Hospital, Karachi. He would take us through the local experience, Pakistani experience of using such implants. And his obviously experience counts a lot to us in Pakistan. And we also wanted to learn from his experience, his initial experience. And that's why I engaged him to present his work and experience, so that he's kind of doing a pioneering work in Pakistan by using this implant at his institution. So let us begin. Again, thank you all the faculty also for sparing time with us on a weekend. Thank you all the participants for joining. We will begin with Mr. Martin to present us the concept of 3D reconstruction of pelvic and acetabular defects. Over to you, Martin.
Thank you. Let's start. And hello to all participants of this webinar. This type of treatment, the partial pelvic replacement in tumor surgery or revision surgery, is medically extremely challenging and requires a high degree of experience of the operating physician. We, as the implant manufacturer from Link, and especially we engineers, can only try to develop the best possible implants and instruments so that operation can be performed smoothly and quickly. And this is where my team from Custom Link and me appear. My name is Martin Herzschuch. I'm product specialist for custom-made hip implants and design engineer. Today, we would like to focus the technical possibilities in the planning and manufacturing of individual implants in the pelvic region. With our partial pelvic replacement, we are able to realize a wide range of pelvic reconstructions. The range extends from minor defects and anatomical anomalies to massive tumor reconstructions. The technical difference between revision and tumor surgery from our perspective is that the defect which has to be bridged by an implant has still to be generated by resection. During the reconstructions, we try to implement different philosophies in order to achieve a stable reconstruction of the natural anatomy. An essential point in this reconstruction, to reconstruct the natural center of rotation, considering different biomechanical aspects and the individual soft tissue situation. But sometimes, of course, we have to accept some compromises. In tumor reconstructions, we are confronted with various defects. At this point, a good cooperation between the doctor and the engineer is absolutely necessary. The resection instructions must be precisely implemented while observing safe zones and in order to completely remove the tumor. The defect to be treated can take many different forms. The most common form is certainly the zone 2 defect shown on the left side. Starting from this zone, the extent of the defect depends on the infiltration of the tumor into bordering areas. For example, the ischiac and the pubic bone are often affected in different extensions. Special challenges for us and of course for the surgeon are again and again defects in zone 4, which must be assessed very critically from a physiological and of course mechanical point of view. After defining the center of rotation, we have all technical possibilities for individually and harmoniously defect augmentation, and we can generate fixation areas with different kind of flanges or something else. And this is possible due to our modern manufacturing possibilities and the high experience of the Link company. Especially 3D printing is playing a more and more increasing role since the last, I think, 13 years. The fixation of the custom Link implants in vital bone is not only solved by simple screwing, but by targeted massive fixation in areas. Here we have the option to plan modular stems as well as special screws to absorb the main forces and to prevent early loosening. There are two ways for us for realizing the joint sliding part with a cemented standard cup or with cementless inlays. In both ways, all combinations from our Link product portfolio are available. And the dual mobility system B-Mobile can be also planned in both variants, which plays a very important role in such cases. Coating options. All coatings of the Link company are also available for custom-made products. For PPRs, for example, our HX coating, which is a calcium phosphate coating, is often used. This coating is applied to surfaces with bone contact for better bone on growth and ingrowth, and especially in cases of long surgery time and increased risk of infection, our silver coating can significantly minimize the risk of infection. When delivering our implants, you benefit from LINX's wide product portfolio. In addition to the implant and its components, you will receive a selection of screws and inlays. Depending on the case, you will receive individual instruments such as saw guides or reaming templates or something else, bone models, a trial implant, and a selection of standard instruments required for the preparation and the implantation. Okay, here I would like to explain briefly how the process of ordering an implant looks like in my company. First, you send us a CT data and the request form. The form contains all the data which are relevant to us assessing the case. In the second step, we reconstruct the defect from CT and generate 3D models and develop a first design proposal, which we send you in form of a PowerPoint presentation and a 3D PDF for a better 3D visualization of the defect and the implant design. Now you have the possibility to bring in your wishes and ideas so that after our revision of the design, a final implant design is fixed according to your ideas. In this step, you also have the possibility to contact the engineer by phone or a web meeting, for example, for discussing and exchanging some arguments. After you have checked our offer and sent us the release documents, we will start the production so that the surgery date can be fixed about 4 weeks after release. But this is, of course, this depends on the implant design and the production effort and a lot of other factors. Yeah. The LINX company has many years of experience in endoprosthetic care, and the planning and production of individual implants. We use the latest manufacturing technologies, for example, the 3D printing as shown, and different coating technologies, which are all available here at our site in Hamburg. Finally, I would like to show you a few case studies and the possible proven features. But I will only present them from a technical point of view and will not show the medical results. I think this is a part of the surgeons and difficult for me to show without privacy release from the patients and surgeons and so on. So I hope Professor Donati and Dr. Ahmed will show you some cases. For example, here we see a large tumor resection. In this case, we have planned 2 resection guides in order to be able to fit the implant exactly at both resection levels. It should also be mentioned here that particular in tumor cases, the exact resection procedure is essential because the implant is designed for exact this generated defect. After reconstruction of the natural center of rotation, the remaining defect was augmented with metal and 4 flanges on the ilium, ischium, and the pubic bone to fix the implant and give them a high rotational stability. The main anchorage was realized here with a trabecular LINX stem. In this case, we supplied the implant with the related stem, closing and adapter screw, our standard B-mobile cup, and the trial implant, and of course, the bone model, as well as the 2 individual cutting guides. Furthermore, the surgeon got a selection of standard instruments for the implantation, and of course, individual surgical technique for this case. Here we see a classic revision implant designed with the missing ventral column of the pelvis. In this case, we planned a cementless inner contour. The surgeon had here the option of adjusting the alignment of the cup using our phase changers and then implementing standard inlays or our dual mobility cup as presented here. The backside of the implant was coated with an HX-coated macroporous trabecular link structure to improve osseointegration and to ensure a good secondary stability. Here we have an example of sacroiliac joint replacement. This was a young, light-weighted patient with a small anatomy. We have built a scaled trabecular link structure on the lateral side of the implant. This ensures that the soft tissue grows into the implant, which provides additional stability to the bone quality. In addition, muscles can be reattached via suture holes. This complex tumor reconstruction is also for a very young patient. For a good stability, we have tried to realize contralateral 3-body fixation with 3 stems. In this case, we have also created a possibility to combine the implant additionally with a spinal system as a second option for fixation. And the suture holes give the option for soft tissue fixation. Yeah. As we were informed, the patient is now well again and everything was worked well and as planned. Yeah, it was a really difficult case and a challenging situation for the patient, of course. Yeah, finally, I would like to mention that we plan and manufacture individual implants in all body regions, especially tumor treatment. For tumor treatment, standard implants often cannot meet individual needs. So custom-made products are the best alternative for the patient and sometimes also for the surgeon, especially for young and mobile people. Yeah. You can here see our growing prosthesis on the left and prosthesis for the upper joints on the right. And here, some examples for the lower extremities. Okay, on this side, you can see our current engineer team and the contact details. If you want further information or a proposal for your difficult case, or you have some questions, please contact your responsible sales partner or directly my team via mail with custom link at linkhh.de. I thank you for your interest, and now it's the turn of Professor Donati. Thanks.
Thank you, Martin. Thank you for a very elaborative talk. In the interest of time, we will take questions and discussions at the end. So, as you said, we will pass it on to Professor Donati now, who will kind of take us through his experience of using mega prostheses after these massive resections. And I know he has a great experience with them. So go ahead, over to you, sir, Professor Donati.
Thank you, Dr. Masood. Thank you for the invitation. I always have a very nice remembering of Pakistan, Lahore, and Karachi. So I like to have this connection with you. Okay, I just focused again on the pelvis because the talk would be too long. So why to use custom-made reconstruction? We have seen that in difficult situations, we can have a perfect fit, a perfect anatomy reconstructed. So we have a better prosthetic position that improves the mechanical stability of our reconstruction. Better mechanical stability, better position means better function. So we can improve the muscular activity, and we hope that it means better durability for the patient, for the prosthesis. We have a long experience with the allograft prosthetic composite in the pelvis. And you see the paper we published in at the end of 2010 to 2011. We had 35 patients with a long follow-up, and we had 8.5% local recurrence, not so bad, 23% of infection, and the Musculoskeletal Tumor Society score has 62%. But the problem is the hip. You see that the hip has a high incidence of complication. So if you have a hip that is not in the correct position, you can see the Gates analysis of this young lady. You can have several revisions in your allograft, for instance, for the hip. So we need something that has a better fit in the patient anatomy. So we have this experience with the trabecular titanium 3D printing custom-made prosthesis. We start in 2014 and to 2020, we had 23 pelvic reconstruction, 5 intercalary reconstruction, 12 osteoarticular. This was the first case performed. The best case for this to start this type of prosthesis, male, 31 years old, after chemotherapy, no tumor in the soft tissue around the pelvis and the socket. So this is the project, the guides, and the prosthesis. And this was the implant, the postoperative X-ray film. You can see the perfect anatomy is reconstructed. And you see the very good contact between the prosthesis and the host bone. And this was the situation after 1 year. You now see the patient walking on the street, on the stairs. You see that you cannot even see which part has been reconstructed, coming up and going down. It doesn't take the canister. So this is a very good result, as you can image. But the problem that we have is the integration. So, because we think that if this type of reconstruction are not integrating during time, we can have failure during time. And this is the situation after 2 years. So basically, we just have a fibrous integration that may be enough. In this case, the company made this very wide hole trabecular prosthesis, and the prosthesis broken. Luckily, the patient doesn't have any problem with this fracture, so we left the patient, the prosthesis inside the patient to now. Then we start our collaboration with Link. This was the first case. You see, is a dedifferentiated chondrosarcoma in the pelvis, a little bulky expansion inside the belly. And that was the prosthesis on site, the stem fixation, dual mobility, solid material, as you can see. You know, with Link, we made some developments like to provide always a bone model during surgery to help the surgeon the day of surgery having references. We use 6.5 screws, cancelo screws that are more effective in the pelvis, and all the tools that are necessary to have a screw direction. Each screw is already projected, so we don't have to make any selection. We know what we have to do during surgery. This decreases the time of surgery. This was the X-ray film at 4 months, and you see, even in this case, at 4 months, the CT scan, the nice contact between the prosthesis and the host bone of the patient. And this was 12 months. You see, you don't see much integration between the prosthesis and the bone. But if the prosthesis is well performed, you don't have any loosening of the screws and the prosthesis itself. The problem is still the issue of the integration. This was another case. It was in a revision case, female, 52 years old, pseudotumor around the prosthesis, implanted 20 years before. We made a silver-coated and anti-allergic custom prosthesis. We prefer to do a two-stage revision in the possibly infected cases like the pseudotumor cases. So we did a wide bone and soft tissue debridement. We put the antibiotic impregnated cement spacer. And then you can see the prosthesis inside. This is the postoperative result. Sometimes it's not easy to have a good fixation in the pubic and ischium rami. So we have to improve a little bit the technology in that place. But in any case, this was 2 years after, and the result is very good, excellent. The patient walked very easily, no infection, and everything is good. So, which is the good things related to the pelvic reconstruction? First of all, the time of custom preparation. As Martin says, we usually have less than 6 weeks from the proposal, the starting of the case and the implant of the case. The time of reconstruction, if you do everything, everything is projected and prepared, the time of reconstruction usually is less than 1 hour and a half. And then you can decrease the time of your exposure of the patient during the operation, and you can have less blood to refill to the patient. And the function is quite high in all the cases. The bad news are that in our experience, among 16 cases, we have 25% of local recurrence. So, but this is related to the tumor. Most of the tumor were high-grade tumors like osteosarcoma, Ewing sarcoma, or dedifferentiated chondrosarcoma. We have quite a number of infections, more in the revision cases than in the tumor cases. We have only 1 case of non-union, but it was not reoperated because the patient doesn't have pain, and the device brackets that I showed you before, in which we again the patient didn't have any pain, so we not proposed a reoperation. So if you look at the infection, among 23 cases, most of the infection are in the revision prosthesis. Why? Because they are often pseudotumors, or as you can see, in 2 cases, we put a prosthesis after infection failure before. So they are potentially cases in which you should be very careful, and we now advise to pass through a 2-stage surgery, always 2-stage surgery. Only 1 case was a real revision case. So can you see that the infection? 2 of the infection in the tumor cases were in the sacroiliac cases. So sacrum, when you resect sacrum or part of the sacrum, you have to be careful. You always need a silver-coated prosthesis because otherwise you can end up with an infection. And in fact, 2 cases were removed, and 1 is still infected with antibiotic suppression, and 1 healed. Among the cases where in the revision prosthesis, we had several removal. I want to show you finally this case. She is a 61 years old female. The biopsy tells us a grade 2 pelvic chondrosarcoma. It's quite a large expansion of the tumor inside the belly. So I prefer in this case to do a 2-stage surgery. Just a little discussion about the advantage and disadvantage. For instance, if you make a flail hip, you don't do any reconstruction. You know that in most places in the world, most of the cases are not reconstructed. And indeed, you can have a reduced time of surgery, less perioperative complication, but still you have long time immobilization. The activity is not very good. You can have pain during time in those cases, and you have quite always bladder and bowel dysfunction, and of course bad cosmetic appearance. You can use allograft prosthetic composite. They are more effective, more cosmetic, more effective functionally. You can have a good host bone integration. We almost never had non-union between the allograft and the patient, but the disadvantage are that they need a wide allograft bone selection. You need a bone bank. You have a long reconstruction time, high incidence of infection, and during time, the result decreased. So custom-made are more cosmetic and functional reconstruction, reduced reconstruction time, and promise a better long-term implant result. The disadvantage are that there is time, of course, of preparation, and they cost more than, of course, no reconstruction over allograft. So I show you this case that was a P1, P2, and P3 resection. We did a first stage surgery with antibiotic impregnated cement spacer. The cement is fixed with the screws, and we inserted a bipolar cap in the cement. After the resection, the margins were free, and we had a little higher grade. So not only grade 2, but grade 3 chondrosarcoma, not the differentiation. So we planned the custom-made implant with Link. So which are the advantages of a two-stage surgery passing through a cement spacer? You have longer time to fabricate the prosthesis. You can check the margin and the tumor definitive diagnosis. Sometimes in chondrosarcoma they can change. You don't have postoperative complication usually if you will need a chemotherapy. The disadvantage are that the cement spacer is difficult to perform and fix. It's difficult to place the prosthesis in the hip rotation center. I mean, the temporary prosthesis. In all the time during the first implant, you cannot make the patient function. You need the cast. You have and then when you do the second stage, you can have possible soft tissue damage during implant. And we don't know if it can increase the infection or lower the infection. Of course, we put antibiotic in the cement. So this was the case during the second stage surgery, and it was quite difficult to dissect the fibrosis in order to expose better the vascular bundle. We need an additional, in this case, we needed an additional pubic incision to expose the pubic symphysis. And this is when we removed the cement. This is not complex. This was the trial prosthesis, so we can have always the model, the sterile model on the field, so we can check everything. This is the guide. You can see the guide on the model, fixation of the guide, and then cutting, better cutting, refreshing the osteotomy line. And we had to suture the bladder wall because I made a little hole inside the bladder. And this was the custom prosthesis. You see that the profile is quite narrow. I asked for a narrow profile because it would be better to make the insertion, having the, as I told before, the fibrous tissue. And then we have also all the targeting device to not losing time during surgery. And we put the cortical screws on the iliac crest. We put the the big screws through the sacroiliac joint, and then finally we prepare the central stem insertion. This is very important, the central stem. You see that you have, again, a targeting device. You can put it there. You put the wire, and then along the wire you make the hole, and then you put the stem inside. So then finally you have a bolt that takes the stem closed, and it cannot come out. It's very tight. So, and finally you put the screws in the pubic rami. We like to use this little plate on the other side because it's much more effective. We have the experience with the allograft, and this system is much more effective when you have to take out everything. So finally, you put a double mobility cap. I like in this case to have the double mobility cap cemented, because you can orient, you can have a second chance to make a new orientation of the cap. Usually I stay very horizontal, and you see the cap inside here, the vascular bundle and the bone prosthesis contact. And finally, you check the stability, and usually they are very stable, even though you don't have the suture of the glutei. That is very important, of course, to make the stability, the final stability. And this is the post-operative check. You see the screws, the stem, they are very important. The screws on the other part of the pubic rami, and the good contact on all over. So finally, I just want to underline the problem of the integration. We ask now to improve the integration of the implant with the surface modification. Maybe we can add also cytokine to attract osteoblast and making a better stability, primary soft tissue stability around the prosthesis. This is important also to fight the infection. And we want to make some changement in the internal design of the prosthesis. I just show you this final slide to see. This was a retrieve case with the old prosthesis that we used. And you see, we had big hole in the prosthesis, and the soft tissue was really inserted inside the hole. This is very important because it's a sort of this race for the space. If you have the soft tissue that integrates very immediately, you cannot allow the germ to make the bacteria colony, and so you can have decrease the number of infection of your implant. Thank you. I hope it was interesting. I'm ready for your question. The next year, if we have we don't have any more pandemic, we will do a course on custom solution for all the part of the body. Thank you very much.
Thank you, Professor Donati. Very enlightening talk indeed. You have a tremendous experience. I have personally witnessed that from you operating on pelvic tumors. Obviously, a great surgical hand, and on top of that, technology is now helping us reconstruct our big defects, which is still a problem in our part of the world. And we will now share, before we take again any questions or discussion, we will now share our local Pakistani experience. Dr. Nasir Ahmed will be doing that. He is a consultant surgeon in Liaquat National neighboring hospital, just neighboring to where I work at Aga Khan. Dr. Nasir works at Liaquat National Hospital. He will be presenting his initial experience of usage of this technology in Pakistan. I'm sure he will touch, besides other issue, on the cost issue also, and the problems we have in procuring such implants from overseas. So over to you, Dr. Nasir, please go ahead.
I will present few of our cases. Obviously, we are very new to this technology. We have recently started doing these custom cases for the last 1 year. And I would like to mention the name of my professor and mentor, Dr. Syed Shahid Noor, who is a very good friend of Dr. Masood Umar and an inspiration for all of his students. So this is the first case. I'm going to jump quickly. The first case actually is of, before I jump onto the cases, I would like to discuss that the challenges we are facing in the revision hepatoplasty is that we are having relatively elder patients who are already osteoporotic and have very poor bone stock. And because of the multiple revisions, the bone stock is again not very good to rely on. And also because of the previous surgeries, they have extensive fibrosis of the soft tissue, the muscles even are not that good because they have fatty infiltration because of the disuse and multiple surgeries, and the anatomy is quite distorted and sometimes very difficult to really find out the anatomical landmarks. So the first case actually is of a 55 years old female with a known case of rheumatoid arthritis, which was very well controlled. She presented to us with the pain in the right hip. Her first surgery was done in 12 years back, and that went well for 8 years. After that, she started having pain, and the revision was done somewhere else. The post-operative recovery was uneventful, but although she never had any fever discharge from the operative side, but she was never pain-free after the second surgery. So on examination, she was a middle-aged obese lady. The general physical and systemic examinations were unremarkable. She was walking with a support and had an antalgic gait. There was a well-healed scar mark, no flexion contracture. The LLD was 3.5, distal neurovascular were okay. So this is the X-ray of her first total replacement primary surgery 12 years back. And gradually, this is the second surgery. Before the second surgery, when the first revision was done, and we can very well see that it is not a simple case. It's preposterity already 3B or 3A, and I think the surgeon actually went in to revise this with a primary cup, which I don't think that is the right choice. So this surgery was done in a staged fashion first. He did bone grafting and revision of the cup, and the femur was then revised after 2 to 3 days. And this is the post-operative X-ray. And these are the X-ray when the patient presented to us after 3 years of the second surgery. We can very well see that this is a preposterity type 3B defect. The femur seems to be well fixed. So we did a preoperative planning. The lab workup was normal and the infective workup was negative. We did the appropriate X-ray and we did a 64 slice CT scan with 3D reconstruction and mental subtraction, and that was sent to the link for their proposal. So the reconstruction options were variable, but actually we just only went for the tri-flange custom-made cup. So this is the proposal which already Martin has shown. I will just quickly went through the way how they proposed us. And this is the 3D reconstruction of the defect. Then the first step obviously is finding out the center of rotation of the hip joint. In this case, it was 3.5 centimeter above the normal, and we thought that we won't be able to bring the hip down. So we requested for a 2.5 millimeter center of rotation from its actual position. So they did this for us. And then obviously designing of the cup with the inclination and the anteversion of the cup, the ilial flange and the ischial flange with the placement of the screw. Another very good thing which Dr. Donati has already shown, that they usually give us an option whether to put in the good bone the trabecular metal bar, which is a very, very solid construct. So this is the option which they gave us, that either we can put a screw into the sciatic buttress, or we can put a fin, or we can put a trabecular link structure. And obviously we actually opted for the trabecular link structure for two reasons. One, it was very robust and strong. Number two is that obviously because of the porous structure, we anticipated that there will be good bone in growth, and that will be good in the long term and longevity of the implant. So this was the slide showing the final picture of the suggestion of the implant and the additional resection we had to do. So for the acetabular side, they actually suggested that we can actually put in a dual mobility cup inside this construct, and the femur we planned that we will retain the femur because it was well fixed. So this is the surgery after exposure. This is the acetabulum and the bone we were left with. They always send a free model of the hemipelvis along with a trial implant so that actually we can practice it before placing the original implant in. And this is how we did it. We took allograft head and filled the cavity in, and over that we did a trial reduction. And this is the original implant. We can see that there are a lot of trabecular metal on the back side, which actually will be very good for the bony ingrowth in the long term. And this is the placement of the implant, the guide wire, as Dr. Donati has shown, that they provide us with the guide wire so that we can see that we are going into the right place, and then a 10mm drill, and then after that the trabecular metal bar, and over that the end cap which actually closes it and hold it from coming back. So this is the final placement, and as I told you that in this case actually we placed a dual mobility cup, and which was cemented into the custom made prosthesis. And this was the final picture because we retained the femur, and this is the final picture after reduction of the hip joint. And this is the closure. You can see a massive incision. Now this was the immediate post-op x-rays, and this is the x-rays at the 6 weeks post-operatively, and we can see that the bone is getting integrated over here. And if you can see on my screen that the bone is getting calcified on the inside of the construct. Now, case 2 is another 50 years old female, which is morbidly obese. She presented to us in March 2020. She had pain both hip joints, left was more than right for the last 1 year. She had a long history. She basically had her first total hip replacement done at the age of 17 years in 1987. Both hips were replaced. For what reason, we don't exactly know. Maybe we anticipate, maybe it was AVN or whatever. So she remained asymptomatic for 13 years until after that, in 2000, she had her first revision of both hips one by one. And then after that, she had her second revision done in 2011, first right and then left a year apart. On examination, she was a middle-aged, obese lady. Her general physical systemic examination were unremarkable. She had an antalgic gait. She was using a support, very difficult to walk. She had multiple scars on both hips laterally, but there was no sign of inflammation. Her distal neurovascular were intact. Then the investigations were all within the normal limit, and her infective worker was also negative. So this was the X-ray which she presented to us in March 2020. Obviously, on both of these, we can very well see that if we just leave the left side on the right side, the left side, which we were planning to do, is almost a pelvic discontinuity. So preoperative planning, all the labs normal, appropriate X-ray, 64 slice, CT scan with 3D reconstruction and metal subtraction, sent to link for proposal, and a mutual discussion was done, and until we finalized the implant. For femoral side, we decided to retain the implant, but the problem was that this femoral implant had a 9-10 taper heads, which we do no longer use. But anyhow, we made effort to retrieve heads, and we arranged for them so that we can actually retain the femur. Otherwise, we also had to revise the femur if we did not want it. So this is the proposal from Martin. You can see the defect on the left side. Again, planning for the center of rotation, along with the inclination and anteversion, and where exactly we want our acetabulum to be. And a trial implant initially. And again, we had, because on this case, we had deficient ileum. So after mutual understanding, we wanted to have a lot of screws in the ileum so that we can have a very good hold. And this is again So in this case, for a dual, for this case, for the inlay, we actually asked for an uncemented press fit dual mobility liner, and which luckily they made for us. And we went for uncemented fixation on the acetabular side as well for an inlay. And this is a custom made liner of the link prosthesis. So now we went for the surgery. This is obese lady, you can very well see. So after exposure, all the previous implant was lying, actually floating in a cavity. So we removed the acetabulum along with the accessories what they were there. There was a pseudo joint formed between the true pelvis and the implant itself. So we have to remove it. But unfortunately, because there wasn't any wall previously because of the pelvic discontinuity, while I was dissecting, we had a little jerk of her left leg. And I thought that I have touched the sciatic nerve with my diathermy. And that was true because the patient later on had sciatic palsy. Anyway, so this is during the dissection. Obviously, as we already discussed, that it is not easy to dissect these things out because the anatomical landmarks are no more there, and you have to rely on your experience of dissection. So this is after removal and retrieval of the previous implant. And then obviously, again, we did the trial reduction and bone grafting of the defect. And this was the 3D printed hemipelvis and the custom-made cup, custom-made trial. These are the few pictures of the original implant. You can again see the same philosophy behind the trabecular metal inside for bony ingrowth and the metal bar with the press fit cup and the dual mobility liner. So we implanted it. So we did bone grafting and trial reduction, and then after that, this is the hemipelvis 3D printed, as I already mentioned. They always send like this, which is very good to practice operatively as well. This is the implant. After the implantation and a press fit acetabular cup with a dual mobility liner and retention of the same femoral stem. Post-operatively, wound was okay, and yes, unfortunately, as we were anticipating, the patient had sciatic nerve palsy. She is now recovering because this has been about 7 months down the line, but the patient is still having neuralgic pains, which we are controlling with medications. See, this is the post-op X-rays down the line, 6 weeks. I'm not showing the immediate post-op X-ray. And even in these X-ray, we can see that in the bone, whatever graft we have placed, luckily it is taking a good calcification and is forming a wall inside and behind the custom-made prosthesis. Now, case 3 actually is a 50-year-old female, hypertensive. She had cannulated hip screw done for neck of femur fracture in 2004. She had non-union and implant failure, and left total hip replacements was done in 2007. Patient went well for 10 years, and then she started having pain in 2017, and she started using the support and became non-weight bearing. When she presented to us, her general physical examination was unremarkable, non-weight bearing. She was walking non-weight bearing with a walker. Surgical scar mark and overlying skin was clean. LLD was 3 centimeter, no fixed flexion deformity, but there was extreme pain on range of motion. These were the X-rays on presentation when she presented to us. Again, a preoperative planning for the prostrate 3B defect. We did the similar things, and for the femur, actually, we decided that we will exchange the femur, and the options we had was a diaphyseal fixation, or we will see that maybe a proximal femur replacement, for which we actually arranged pre-operatively. So we did an extended trochanteric osteotomy to remove the stem and the cement, and we can also see the cup, which is actually inverted. After removal, everything, and clearing the fibrosis from inside the acetabulum, this is the defect we were left with. Again, a trial 3D model, allograft, the original cup, the original model, the original implant, and then implanting it inside. Similarly, now in this case, we had one problem is while we were implanting, the bone was so much osteoporotic that actually we could not really had a very good hold, especially in the ischium of the screws. So we had to we placed the screws with the cement in. So we cemented the holes, we drilled it, we placed the cement in, and then actually we screwed place the screws into the ilium and ischium for a good immediate stability of our implant. Now again, a press fit cup, dual mobility. So on the femur, as I already discussed, that because it was shattered and it was not possible to place a diaphyseal type of implant in it, so we went for the proximal femoral replacement. So this is the final picture after complete replacement. And you can see in this picture that the bone graft is there, and also there is cement around the screws as well, because we had no good option other than this to make our implant immediately stable on fixation. Now, case number 4 is the last case. She was a 60-year-old female diabetic, which was very well controlled, had primary total hip replacement 3 years back, but she continued to have pain. When she presented to us, similarly, general examination was unremarkable. Her LLD was 2 centimeter and painful range of motion. So patient actually had an acetabular fracture in 2017, but she presented 6 months later to her primary surgeon. So instead of reconstructing the acetabulum, and obviously the head was not there, so the primary surgeon planned for a dual mobility primary total hip replacement, and this is what he did. This is the initial X-ray of her, but unfortunately, for some reason, maybe a low-grade infection or whatever, this actually failed, and it turned out to be a Peprosky 3B defect again. And with this, she presented to us. We did an infective workup and did an aspiration at that time, which turned out to be negative. So we planned for a custom-made prosthesis, did the same thing for femur. We actually decided that we will revise the femur with a diaphyseal type fixation or with a cemented implant. So unfortunately, while the implant was made and was shipped to Pakistan, the patient developed a symptomatic UTI for which she was treated, and the surgery was rescheduled after normalization of the infective markers. So when we after clearing all that, when we opened the synovial fluid, actually turned out to be seropurulent. So basically, because of the UTI, she got the synovial fluid or the hematoma infected, and operatively we did a leukocyte esterase test that also turned out to be positive. So we postponed it and we did a first stage revision. We took multiple deep cultures in the first surgery, and that turned out to be E. coli. And with the ID consult, actually we kept her on antibiotics for 10 weeks until her all the infective markers turned out to be negative and clear. So after doing all that, it took about 2 to 3 months, and then we went in for a second stage revision and implantation of the implant, which was already made. So this is the 3D model and trial model, and then the original model, original implant. So this is after exposure. Luckily, after exposure, there wasn't any sign of infection. The tissue was very clean. So I was very happy to see her that the debridement was very good. So this is after the implantation, again, with a press fit cup and a dual mobility liner. And we did a cemented long stem femoral stem on the femoral side. And this is the post-operative x-rays. So I would say in conclusion that according to the registries, the revision hip surgery is on a rise. And severe cases like Peprosky 3B and pelvic discontinuity cannot be adequately treated with the conventional on-shelf implants, as we have already seen. And custom acetabular implant is a very valid option for these type of patients, as it provides immediate stability and long-term stability by means of osseointegration on the trabecular surface. Now, the problem we face is one, obviously, during the implantation is the non-availability of the locking screws into the custom-made implant. Because in 2 cases, we had to carry out the cement, the last 2 cases, which I showed you, to fix my screws into the ilium and ischium, because the conventional screws did not had any hold. And lastly, I would say, as Professor Masood Umar rightly said, and Professor Donati also mentioned at the end of his presentation, that the cost is obviously a big issue for countries, third world countries like Pakistan. But that does not deny that we do not need custom-made prosthesis, because the revision is increasing in Pakistan as well as it is increasing all around the world. So this is one thing actually we need to discuss about it. Thank you very much, Dr. Professor Donati and Professor Masood Umar. I think you can take up from there, and this is the end of my presentation.
Thank you, Dr. Nasir. Sorry, indeed, you're doing a great job in Pakistan, pioneering along with Professor Shahid Noor under his guidance. We are very happy to see this progress and this technology being used in Pakistan also, despite all the limitations and especially in cost issues that we have in our day-to-day dealing of patients, especially when they are self-paying. But anyhow, let us move to some discussion points and Q&A session. We still have about 20 minutes. I had some questions here. First question is for Martin. Which material and method are you using for implant manufacturing? Electron beam or laser sintering?
Yeah, we use the EBM technology, so electrobeam melting, and the material is titanium for the implant, and also every screw for the implant, and the cutting guides or the templates are from sterilizable plastic. It's a polyamide, and or the cutting guides can also be from steel, medical steel.
All right. Thank you. Next question was Gigi. Go ahead, Nasir Saab. You want to add something?
I want to ask from Professor Donati that the first case you showed of the titanium cage, I think the young guy who had later on fracture of that cage, was that a different company design, different from Link, or it was also of Link design?
It was a different company. We start with an Italian company, then we move to Link. Yes, they do quite a different type of internal design, I would say. And we are discussing with Link to do something more integrated with the soft tissue, because this will be an issue during time. That is very important. As I told you, once on one end for the infection, and the second for the long time stabilization of our prosthesis.
Yes, obviously it is very early for us to show any cases of osseointegration, but I hope down the line, 5 years and 10 years, I will be presenting these cases in various forums, and we will show you as well that how they integrated. Martin obviously is usually, we are communicating with him through our local vendors, and we are having a good communication with Link in that.
Okay, so for those who want to ask questions, please write them down in the Q&A column. And next question is, let me find out. Second case, the femur 2 is more than 20 years down the line. Wasn't it safe to revise it as well? I think it is for you, Dr. Nasir.
Nasir, ji.
Second case, the femur was 20 years down the line. Why didn't you revise that one?
No, this was the second surgery that patient had was in 2011. So 2011 means that in 2020, it will be 9 years. Yes, yes. So, but because the femur was well fixed radiologically and clinically, we did not went for that. Although we planned that we will remove, if we had any problem, we could have done revision as we did in other cases. That is not a problem.
And the other question for case number 2 was, is it the press fitting, is it metal on metal, and what was the graft source, autograft or allograft?
They all are allograft. We are actually in the phase of establishing a full-blown bone bank in our own setup. Aga Khan University is the pioneer. Professor Masood Umar already has this facility for a very long time, but now alhamdulillah, we are having it for the last 1 year, and we are also working on the same lines. So we used allograft heads, and these heads are saved according to the guidelines from the patients who are undergoing neck of femur fracture.
And the last question here was from Dr. Rajab. What was the cost of these implants in Pakistan?
This is the implant which we made from Link actually is costs around 25 lakhs to 30 lakhs. It depends upon the design and the various options we will order for. If, for example, you will only go for the tri-flange design and do not ask for a custom-made insert or the dual mobility liner, then actually you can put any on-the-shelf dual mobility which is available in Pakistan, and then the cost will be less. But if you are also heading towards further options, obviously the cost will increase.
Okay, we have Professor Suhail Hafiz, our chairman for the Oncology Forum of Pakistan Orthopedic Association. He's put in a couple of questions. Does the custom-made jigs always ensure resection as planned? And how do you correct for any discrepancy in resection? Maybe Dr. Donati, you can take this up.
Yes, usually we did a study among the first 10 cases we did, and we had only a case in which we did a 4 millimeters discrepancy since the project in the real operation. That all the other 9 cases, they have only 1.5 millimeters of difference since what was projected. That means basically the saw bone that you produced when you saw the bone. So I think that if you follow closely the indication, you don't have problem with the good contact of the prosthesis. Of course, you need to have the situation under control. You cannot do an osteotomy with the saw if you have the patient bleeding or something like that. You have to have all the situation under control, and you have to make very closely the cut of the bone, and then you will end up with a nice contact.
The second part of the question was any experience with tantalum?
You mean my experience with tantalum?
Yes, yes, yes.
I have quite a large experience with tantalum. As you know, I try to use everything in the pelvis. Actually, we are a little bit more addressed to the custom prosthesis, even because tantalum is not so cheap. So it's quite expensive as the custom prosthesis. Tantalum is a fabulous material because probably has the best bone grip that you can have with any other material, even though the 3D printed titanium with the EBM system is quite good. But in any case, it's not possible to make custom with tantalum. So if you want the tantalum, you have to just cover your surface, the bone contact with the tantalum, but it's so difficult and so expensive that I don't suggest you to do it. We try to do something with Zimmer, but it's over any body possibilities. So, but in any case, tantalum, if we should do something with tantalum at the same price of the titanium, I would probably prefer to use tantalum.
All right, thank you. Next question was from Dr. Wajahat. What possible options do we have to revise if the custom implants also fail? Dr. Donati, please.
You have to take out everything and put cement with antibiotic. No way. You know, of course, I don't think.
I think he meant mechanical failure. Have you had any
Okay.
mechanical failures? Non-infectious?
Okay, I had basically only two complications: infection and local recurrence. So local recurrence, basically you do an hindquarter amputation. And if you have the infection, you take out everything and you leave a flail hip. So with the mechanical failure, I just have the experience of that case, but we didn't revise him because it's only the posterior part and he doesn't have pain. So I think that with the link prosthesis in the pelvis, you'll never have problem because they are very solid. Even too much, I would say. But you will never have problem with a fracture of the prosthesis. The thing is, probably in the future, you have to be careful to use the dual mobility in a revision case. You have to use the dual mobility. I prefer to use with the cementation because you can orient the cup during the operation, because sometimes the custom is not in the position in which you project in the revision case. The revision cases are more difficult to achieve the correct position of your implants. So you have to be very careful, and I prefer to have a possible second chance to further orient your cup.
Okay, this is I think very good advice, Dr. Donati. Thank you very much. The first case actually we did was the cemented. So the thing which was in our mind was that whether in terms of longevity, that cemented cup would be better, or press fit dual mobility design would be better if, for example, the positioning is not a problem. What about longevity of the cup? What is your experience?
I don't have a direct experience. I mean, I don't have so many cases, but basically, as you know, if you make a revision in the case like you showed us, you don't have such a important functional activity by the patient in the future that makes you in scare of a loosening of the cup. When you cement the cup inside your titanium, there's no problem. You will have the prosthesis lasting all the life long. I don't see any problem with that.
Okay. Thank you.
Okay, Dr. Donati, have you had a situation in tumors where you had to revise your resection intraoperatively on a suspicious frozen section, and then, which happens very occasionally in oncologic surgery, then you have to go a bit higher up, and that would kind of make the fixation of customized implant difficult. And what's your solution in that case?
I never had this situation, but if you have a tumor that is quite aggressive on one end, or on the other hand, so dedifferentiate chondrosarcoma in the pelvis, or a Ewing at the end of the chemotherapy that you are not sure that it will stay there beside the end of chemotherapy, it's better that you do a two-stage procedure. You take out the tumor, you control your margin, you control better the tumor, you have better indication about the prognosis of the patient, because if you have a tumor that is largely vital, not necrotic, I don't know if I put a custom prosthesis, because it seems to me something that would be not necessary. And so I prefer to use the two-stage procedure. If you have a stable low-grade chondrosarcoma, tiny osteosarcoma, so I wouldn't have that scare about to be not proper in my resection with the local recurrence. Of course, when we project the cutting guide, so where we put the cut in the bone, we stay a little bit larger than we probably would do during a regular case in which you make some type of reconstruction, because you have the possibility to have a better fixation with the custom prosthesis, even though you have less bone.
So in that case, sorry, go ahead.
No, I mean, when you project the case, you have to stay large. There are no problem. When you put the stem inside and the screw around, the prosthesis cannot fail.
I just wanted to ask, in the case of a second stage for after a tumor resection, how long after the primary surgery do you do the second one, preferably in terms of chemotherapy, post-adjuvant chemotherapy?
I would prefer not to take the cement too long. We have the experience in the revision cases in the lumps, when we take the cement more than 3-4 months, the cement is going to be colonized by the germs. So it would be better not to wait too long. I would say not more than 4 months.
So even in case of Ewing's, that would kind of finish the chemotherapy period by that time.
In the Ewing patient, we usually do chemotherapy, radiotherapy, chemotherapy, and the resection only at the end. We don't do the resection during the pre-op and the post-op chemotherapy. In most of the cases, unless the case have a very good answer to chemotherapy and is quite tiny. If the tumor is really limited and it responds very good to the chemotherapy, so it like in the first case I showed, it was a case in which after the 3 cycles of chemotherapy, it shrank inside the bone very, very nicely. So in that case, you can do it. But usually in the bigger cases, we like to do radiotherapy in between the chemotherapy. And if you have, the only issue is if you have a child that is less than 12 years old. So in that case, you have to make the decision case by case.
So have you had any chance of a growing pelvic prosthesis so far?
I don't think so.
All
One thing,
right.
Professor Donati, what is the average time when you first see the patient and you decide that I'm going to resect it, and then you order a custom prosthesis? So the time you order the prosthesis and you implant it. So what is the average time in between?
Usually, as I wrote, is 6 weeks.
Okay.
In 6 weeks, you can do everything. It depends by you, because most of the time the engineers are quite fast. Most of the time we lose time to make decision. Oh, I want to put something. Actually, after 23 cases performed, we have the idea quite clear, and we don't lose time when you have to make the project. But in the beginning, you know, I don't want the screws, I want another screws. But I know actually that the screws doesn't work very well in the pelvis. What is working in the pelvis is the central stem, and you have to make the little plates around, because the prosthesis theoretically can have rotational, rotational stresses. But if you put the little plates, like the big plates that you use in the revision cases, you don't have problem with the rotation. You have the stem, you don't have rotation. You can put 2 screws or 22 screws is the same.
Okay. That's where that the number of screws are not going to matter. Martin, can I ask you, do you have the technology of making these screws locking screws, as we have a locking plate system? Can we make them locking so that when we are tightening them up, these 4 screws actually get locked into the ilial flange?
Yeah. At the moment, we don't have the chance to make it as locking screws, but we are working on that topic because there are a lot of surgeons who want it.
Yeah.
But it
And
takes
actually,
a few
there is one
weeks
case
or
with you.
months.
You're actually having one case on which people are now working, and probably you will be sending us the proposal. If you can make screws in that.
Yeah.
Okay.
We try to.
There are a couple of more questions. Let me go to them. A lot of people have registered in this with Masood Umar as my primary name. I'm surprised so many Masood Umars are asking questions. So anyhow, the question was for Martin. Cutting jigs are manufactured of which material?
Normally, it's made from steel, but there are some cases where we made it from polyamide. It's the white plastic, like the bone model. So it depends on the case, but normally steel.
Steel. All right. Next question is for Professor Donati. With the cutting jigs, have you faced any difficulty in fitting due to soft tissue margins? Any tips to circumvent that issue?
Usually you have to be careful to scrape off carefully the soft tissue from the iliac wing, where you have to place the your jig. Usually you have the jig and the model of the bone on the field, so you can really check where the jig has to be placed, and you can do the same in the patient. The only thing is to be very careful to scrape up the soft tissue, because the engineer, they don't see the soft tissue, they just see the bone. Many times they also make the instruments like you don't have any muscle, you don't have anything around your bone. So you have to be careful when you make the project, because they don't know that you have the glutei, you have the vessel inside, you have the bladder, you have everything. So, but I'm joking, of course. But in any case, you have to be careful. And if you are careful, you will see, usually you will see that you have only one position in which you can put your jig. There is no possibility to change it.
Just as a correction, this was Dr. Atar Siddiqui asking these questions on my behalf under my registration name. Anyhow, any more questions? Any discussion points? We have just last 1 or 2 minutes in the session. Maybe we can, Saad, you can open the mics if anybody wants to ask any direct question.
Sure, sir, I can.
And I would also request all participants to open their cameras, please. We can take a group photo. Saad, can you please handle that?
Yes, sure, I can.
Requesting all participants to open your cameras, please. We'll take a group photo. So nicely attended. We had over about 50 participants. अभी भी कुछ please सब लोग अपने cameras खोल लें, so that Saad can take a group photo, please.
Once the camera is open, हमें पता चल जाएगा कौन-कौन मसूद उमर के नाम से जो है ना वो register हुआ होगा.
Exactly. So Saad, have you done that?
No, I need a couple of minutes.
Any last burning question from the crowd? Saad has opened mics of every participant also. So I must thank Professor Donati. Thank you very much for taking time out and sharing with us your valuable experience. You have very rich experience in Bologna, obviously. And Dr. Donati is a great pelvic surgeon, as I have myself witnessed and learned a lot from him. His pelvic dissection techniques, very immaculate. And so thank you, Martin, also for providing the basic framework of this webinar and adding the industrial aspect behind the development of these complex implants. And lastly, thank you, Dr. Nasir. Indeed, you are the pioneer in Pakistan doing such a tremendous service to our patients, and the state-of-the-art technology you're bringing from overseas to Pakistan and helping our patients get back to their feet and get back to normal return to life. So tremendous job. Again, lastly, thank you all the participants for bearing with us last 90 minutes. I hope it was useful. Please do let us know of your feedback and anything we can add to this webinar. We'll be holding similar webinars in future also on complex joint arthroplasty. And thank you, Saad, lastly, to help us arrange this webinar. So I would now close the webinar now. Thank you all again.
At the
Bye-bye. Have a nice weekend.
excuse me, sir.
Peace out.
We are going
Yes.
to have a group photo. I request all the members or participants to please open their cameras so I can take a snap. Dr. Athar.
Okay.
Yeah. Other Dr. Rajab, Dr. Arif, Akil Ahmed. I request all Dr. Arsalan, Dr. Tashfeen, Ahmed Ghaznavi, Ansar Shafiq, Zishan Saab. So I said 1, 2,
चरण जी
cheese. Okay?
जितने खुले हैं वो ले लो हम.
Ji sir. 1, 2, say cheese. Thank you so much.
All right. Thank you. Bye-bye. Have a nice weekend, everybody.